Okay, today we're going to kind of go through a grab bag, mostly talking about cardiac tamponade, which is my favorite thing. And then a few other cardiomyopathies kind of sprinkled in there. So not comprehensive about all different versions of cardiomyopathy, but just a little bit of a grab bag of topics that are relatively rare, so you might not always see them, but hopefully you get a little bit of a input here. So when I was a resident in the CCU, my month on July of my senior year, I admitted tamponade every other call night. So every 6 days, because we were on call Q3, I would admit tamponade. It was just what I did, kind of my thing. So I'm going to tell you the most dramatic of those cases to remind you. So at about 2 a.m. I was called by the ER, and they said I have a patient in tamponade. And I was like, well, I'll be the judge of that. So this woman was a 43-year-old woman from the Philippines, and she had initially come to an outside hospital complaining of chest pain and some shortness of breath. But they did a CT scan, of course, right? And the CT scan made everybody freak out because it showed this large circumferential pericardial effusion, 4.6 centimeters. That's a lot. Anyone know what you can start to sort of see on imaging? Like, you and I probably don't have any discernible distance between our pericardial layers on a CT scan. So 4.6 centimeters is a boatload. And there was this mediastinal mass as well as multiple pleural masses. So obviously very concerning, and so they had urgently transferred her over to our hospital for surgical evaluation because they thought all this in her chest needed surgery. And so I came down to the ER, and literally they had the pericardiocentesis kit out, and I practically had to stop the ER physician who was like waving the needle above the patient's chest, like, hold on, let me just evaluate her. Probably if the patient's not dead, we don't need to do that right just this second. So if you are called down to evaluate this patient, what's the first thing that you want to do in terms of evaluating her? Good. So what sort of hemodynamics are you interested in? Good. Okay. And then what else? Yeah, obviously. Good. Okay. So her blood pressure was interestingly 150 over 110, but her heart rate was 110. What are you thinking when you see these vital signs? You thinking, go ahead, stick that needle right into her chest, go for it?
She looks pretty stable.
Oh yeah, so her blood pressure is at least, it looks like it's perfusing. What about that heart rate?
Compensated.
Yeah, so hard to say, but it's not normal to have a heart rate of 110. So there's a hint that something is going on there, but she does have, quote, normotension, or her diastolic blood pressure is actually high. And then when you started to ask her some questions, because obviously you're going to examine this patient, it was very interesting because you'd say, ma'am, how do you feel? I feel fine. And then you'd ask her, and how old are you? I feel fine. And do you know where you are? I feel fine. I feel fine. So she was perseverating on that one answer and also speaking in Tagalog and not in English. So at first I thought, well, maybe she just doesn't speak English, fluently, and so that's why she's speaking Tagalog. And you'll see she ends up in the CCU. One of our CCU nurses, who's also Filipino, was talking, singing to her in Tagalog. So I just assumed this woman probably didn't speak English fluently. What else are you going to look for on exam if you're worried about this 4.6 centimeter pericardial effusion? JVD. Good. So you want to see if she has any JVD. I could not appreciate any at the bedside, but that's very important. What else on your exam? What's your classic triad? Triad. Good. Muffled heart sound. So I couldn't hear her heart sounds. They were quite distant. You got it. Pulsus Paradoxus. So we're going to go over how to measure that. Raise your hand if you know how to measure a pulsus. Raise your hand if you've ever measured a pulsus in a patient. Okay. Yes, I know that we had some last month together. So not many of you. That's why I'm going to teach you today. So this is the most interesting thing to me on her exam. We're talking about tamponade, guys. You can go ahead and sit close to the front because I know you want to learn a lot. Her distal extremities were cool. And I'm not just talking like, there was no mistaking that her legs were cold. So that's automatically changing how I'm thinking about this woman because even though her blood pressure is, quote, normal, her distal legs are cold. So I measure a pulsus on her and it is 30. Anyone know what's normal? Less than 10, 8 to 10. So she has a whopping Pulsus Paradoxus, and she has what is probably my favorite physical exam sign. It's called palpable pulsus. So you're feeling her pulse. She takes a deep breath in. Her pulse goes away, and then she breathes out, and it's there again. And you can see she ended up with an A-line in the CCU. You could actually see the difference in blood pressure between inspiration and expiration. That's not reliable, by the way. But my measurement was, and the fact that she has palpable pulses, I've seen that twice in my life. Because like I said, I always admit tamponade. But that's very impressive. Her lactate was 7. So what does this whole picture tell you? Is she perfusing, yes or no?
No.
She's not perfusing despite this normal blood pressure. So what's your etiology here? Girlfriend's in tamponade. With this pressure, she is in tamponade. These are her scans, and it's hard to see because the contrast is not lighting things up appropriately here, but this is at the level of the aorta here. So this is actually the anterior mediastinal mass. That's not her heart. It was a very large mass. And now here we're down at the level of the ventricle, and all of this is a pericardial effusion. Right, so you could hit it if you were blind, but that's a lot of fluid. So I call the interventional attending, Jeff Trost, and he comes on in and comes to the bedside. And he gets out 1,700 cc's of bloody fluid, like frankly bloody. How many cc's do you probably have in your pericardium right now? About, maybe 30 to 50, not very much. So this is obviously an enormous amount. But if you think about your differential diagnosis, this woman is from the Philippines. She has some masses in her lungs. To me, I was actually quite concerned about a tuberculous pericardial effusion. So he actually performed the pericardiocentesis in a PAPR, which is just badass. You'll have to edit that out, sorry. But that's pretty awesome, right? And as soon as he took the fluid off of her, hemodynamics improved, and girlfriend could speak English fluently, which is the coolest part. That showed you she had cerebral hypoperfusion when she was just saying, I feel fine, and speaking in Tagalog. And as soon as we took that fluid out and allowed her perfusion to improve, she could speak English fluently, which was a surprise on rounds the next morning when we went in to see her. The eventual diagnosis after a lot of workup was she actually had malignant thymoma. She's actually still alive today after getting treatment for this malignant thymoma. So let's talk about cardiac tamponade. So the pathophysiology, this is very important to understand what's going on here. So the basic idea is that the pressure inside the pericardial space, which is normally negligible, it's essentially 0, that pressure becomes greater than the intrapericardial pressure. But remember, I've taught you about what the pressures are inside the different chambers of the heart. So obviously the diastolic pressures are going to be lower, and which pressures are lower, right-sided or left-sided? So the right side is going to be impacted preferentially over the left side. So that's why you'll hear when we look on echo that we're looking at the right side of the heart to see if we have evidence that the right side is experiencing all this external pressure. So what happens is that you get impaired ventricular filling eventually. This is what tamponade is from. If your left ventricle is underfilled, for reasons we'll explain in a second, then your cardiac output is decreased and you'll end up in hemodynamic collapse. And that's the reason why tamponade is such an emergency. But you got to remember that this is a clinical diagnosis, so there's no echo test. There's nothing you can do that absolutely 100% cinches the diagnosis of tamponade besides your clinical diagnosis. That's evidenced by the fact that this woman was normotensive. 150 was her blood pressure. So if you just got that report over the phone, you wouldn't think she was in tamponade, but she was absolutely hypoperfusing at that pressure. So we talk about this sort of classic triad, and we mentioned some of those when we were evaluating this woman. Elevated JVP, right, because you're experiencing this change in your preload, which we'll talk about in a second. So JVP is up. The heart sounds are distant because you now have fluid in between you and the heart sounds. And then maybe plus or minus hypotension. And then the other things that I'll add into this is that they can present with dyspnea or chest pain, but they don't have to necessarily. You've probably all seen people, oncology patients who have effusions. Maybe they're not in tamponade and they don't have any symptoms at all. And then the Pulsus Paradoxus is really, for me, that's the linchpin. That's how I decide if I'm sending this person to the cath lab or getting them intervened upon immediately, or if I'm just going to watch them. So let's describe what Pulsus is. I'm not going to ask any of you to do it because it's complicated, so I'm going to take you through step by step. Firstly, it's not actually a paradox, right? This is actually just an exaggeration of normal physiology. So let's go through what happens when I take a deep breath in. I inspire. What happens to my intrathoracic pressure? Increase or decrease? Decrease. Take a deep breath in. I decrease my intrathoracic pressure. What happens to my venous return? Increase or decrease? It increases, right? Because there's less pressure impeding it. So decrease intrathoracic pressure, increase venous return. So now, in a normal heart, in you or me, I now have more volume going into my right side than what I have during expiration. So what happens to the configuration of that RV? Well, in you or I hope, if we have a nice compliant pericardium, then my RV free wall will just shift out a little bit, right? To accommodate that extra fluid. No problem. It shifts out. However, your septum is probably going to move a little bit towards the left, yeah? Because the RV is changing sides. So that's what happens in a normal person. Now, let's say that I now take a hose and I just pour some fluid into your pericardial space. So I've now increased the pressure in the pericardium. So now my pressure in the pericardium, let's say that it's about 10 or 15 millimeters of mercury. So higher than my diastolic pressures on my right side. Okay, so now we go through the same experiment. Take a deep breath in. What happens to my intrathoracic pressure? What happens to my preload? My venous return. Okay, but now my RV the free wall cannot expand out, right? Because it's stuck with a pericardium. So what's the only other direction that it can go to accommodate that increased filling? Septum is going to bow towards the left. Now, because I'm in a fixed pericardium here, when my septum bows to the left, what happens to my LV filling? Beep, decreases. What happens to then my pulse pressure? Going out, that was not an up, that was a going out of my left ventricle. What happens to that? You have less cardiac filling, so your stroke volume is less, so your cardiac output is less, and therefore your blood pressure is less in that beat, right? So that's exactly what a pulsus paradoxus is. I take a deep breath in, my blood pressure goes down because of everything we just did. Deep breath in, intrathoracic pressure down, venous return up, RV can't shift this way, so the septum shifts this way, LV filling down, therefore less coming out, therefore less blood pressure. Yeah? Easy, right? Easy. We're going to go through that again later. So that's why with inspiration, the blood pressure goes down. It's just a more exaggerated decrease when you have this fixed pericardial space. So we say usually 8 to 10 millimeters of mercury is acceptable. Once you have more than that difference between inspiration and expiration on your blood pressure, then you have a pulsus paradoxus. So, okay, that theory is fine, but how do you measure this? Because it's really difficult to time inspiration and expiration, yeah? So some people will tell you, we'll just have the patient take a deep breath and then measure their blood pressure while they hold it and let it out, and then just measure their blood pressure during expiration. That never works. Don't ever try that. I'll kick you in the teeth if you try that. Just kidding. Okay. Woo, dead crowd today. Good. All right. So here's how I measure it. I take a manual blood pressure cuff, and first I get the automated cuff in the ICU or the ER, wherever, to give me a rough estimate of where their blood pressure is. So let's say it comes back at 110/80. So now with my manual cuff and a quiet room, I will inflate my blood pressure cuff usually 20 to 30 millimeters above whatever I got on the automated cuff. So in this case, I would inflate my blood pressure cuff to 130. So I inflate it and I make sure that I'm not having to bend over because this takes a while. So I have the patient in a nice comfortable position. I have my stethoscope on. I inflate the cuff up to, let's say, 130, 140 here. And then with them spontaneously breathing, I slowly let it down. And we're talking literally this fast. Super slow. And what I'm listening for is the first time I hear a carot cough sound. Because what you'll notice is, in all of us, you'll hear that first carot cough sound. So the difference between the first time I hear it and when I hear it with every heartbeat, that is my pulsus. Now you have to go slow because depending on how fast the patient is breathing, you need to catch inspiration and expiration. So Trick, some of you were on with me last month when we did this. If you have a patient on the ventilator, remember that it's swapped, right? Because you're delivering positive pressure during inspiration. So the lower number will actually be expiration, but that doesn't matter. Just make sure the respiratory rate on the vent is high enough that you don't have to stand there forever. So if the respiratory rate is only 8, I'm gonna have to be sitting here for minutes while I'm letting it go down. So we literally just had them crank up the rate to 24 so that we could do this while the patient was breathing. So does that make sense? I'm going to show you this in graphical format. So again, you're looking for the difference between the first time you can hear a carot cough sound and when you hear it with every single beat. The difference between there is the respiratory variation. Now I've been fooled before because I went too fast and the patient was breathing slowly, so I didn't actually catch inspiration and expiration on the way down. So I was like, there's no pulsus. The patient had a pulsus of 20. Good job. That's when I was a fellow. Good job, me. Okay. Don't worry, we took the fluid off at the bedside. It was kind of nuts. So this is just a visual representation of what we just talked about. So this is if you have a tense pericardial effusion. So remember, the pressure in here is going to be greater than the diastolic pressure in the right side. So I take a deep breath in, my intrathoracic pressure decreases, my venous return increases, my RV fills more, and the only place it can go is the septum is the only mobile part of this RV because I'm restricted over here. So the septum bows over into the LV, my LV has decreased filling, with decreased LV filling my cardiac output goes down, and because it happens like that, there's no time for my peripheral vasculature to accommodate, so my blood pressure concomitantly goes down. So that's the mechanism there. And then this is just a visual representation of what we just talked about. So here is your blood, where the cuff is inflated to, the sphygmometer. Try saying that 10 times fast. And then here you're deflating the cuff very slowly. And here is what noticing the carot cough sound. So the first time I hear it is here. Yeah? Get it? And so between the time I hear it first and the time I hear it consistently, this is my pulsus. So it was at 110, now it's 90. This is a pulsus of 20. This person is in tamponade. Or maybe has a PE, that's the other option, but mostly tamponade. And then here is what the arterial tracing might look like. Do you see how this blood pressure is changing with respiration? Now sometimes people will call me and say, on the A line I can see the pulsus. The scale is really not well adjusted to see that, so I will never make a diagnosis just based on the A line, but if the pulsus is wide enough, you might be able to see this respiratory variation, and this is just representing the intrathoracic pressure. And then again, we have this effusion. Here's our right ventricle. I take a deep breath in during inspiration, the RV fills more, the LV underfills. Here's expiration. The septum's allowed to go back. As opposed to normally, my RV free wall is just able to bulge out, and then might have the septum go a little bit over towards the left with inspiration, but not enough to make a significant difference in the cardiac output beat to beat with respiratory variation. Everyone totally an expert on cardiac tamponade now? Okay. So this is like my favorite pathophysiology. I think it's really fascinating. What does this ECG show? Besides tachycardia. Yeah, electrical alternans. So can you see how these are different magnitude, the QRSs? And sometimes, like here, for example, you'll actually see the vector totally shifts. So it might, here I'm up, then I'm down, up, down. That just represents this. The heart is swinging inside that pericardial effusion. So this is the electrical representation. True alternans, you're actually supposed to switch axis, but this is close enough. Yeah? So if you see this is evidence that you have a pericardial effusion. That's not the same as tamponade, but this would tell you that you have enough fluid for the heart to do this. Okay. Now, echo findings. That's beyond the scope of what you guys need to know, but I just want to give you a brief familiarity because you'll see this. So clearly here, this is your heart. Left ventricle, left atrium, right atrium. Here's a large pericardial effusion. Everyone can see that? It's circumferential. Now, this is during systole. So during systole, you expect the RV to be squeezed down. During diastole, your right atrium should not be completely collapsed. It should be squeezing, right? Because ventricular systole is, because atrial systole occurs during ventricular diastole, right? So if I'm calling this diastole overall, my atrium should be filling into my ventricle. However, what you can see here is that the whole right atrium has basically collapsed or invaginated. So see here, you can see the edge of the right atrium, and now it's all the way collapsed in. Remember what I told you about what happens? The pericardial pressure becomes greater than the diastolic, the lower pressures inside the heart. And so what you're seeing here is that the pressure right here is greater than the pressure here. So when we see right atrial or right ventricular invagination or collapse, that's an echo evidence of tamponade. Again, it's not quintessential for the diagnosis, but this is highly suggestive. The other thing is we can actually measure. I just talked to you a lot about how inspiration and expiration changes the output from the ventricles. Another way to look at that is looking at the flow into the ventricles across the mitral and tricuspid valve. So we can actually look at, with inspiration and expiration, how the flow, this is the flow in centimeters per second, how it changes across the mitral and the tricuspid valve. So what you can see here is that, see right there, the flow is pretty high, 120 centimeters per second. And then when they take a deep breath in, the flow decreases significantly. And so there are criteria for how much it should decrease across the mitral or across the tricuspid. You don't need to know that. Cardiology fellows to be, you will need to know that. But this is one of the ways on echo that we look. So if you're suspicious of tamponade, you have to specifically tell that, because echo techs are not going to do this test on every single patient. If they see an effusion, they often will, but you're going to need to also specify that that's what you're concerned about. So those are some of the echo parameters that we can look at to help us distinguish if there's evidence of impending tamponade or echocardiographic evidence of tamponade. Another very important point is that just because you have a pericardial effusion does not mean that you're in tamponade. How many of you have seen patients with large pericardial effusion just walking around? Yep. And did you guys stick needles in all of those effusions? Good. You shouldn't have. You can actually cause more problems. So I've seen a chronic dialysis patient who frequently missed dialysis, so his BUN was very high, have a uremic pericardial effusion that was 6 centimeters circumferentially. We left that bad boy alone. The team changed, new year came around, everyone's like, oh, we should diagnose this, and tried to stick a needle into it. Boyfriend went into tamponade that night because he actually bled into the pericardial effusion. So that was bad. So you leave it alone if it's not causing any trouble. It's important, though, to recognize that your pericardium, I was trying to think of a good example. It's kind of like the opposite of a balloon. So acutely, you cannot fill it quickly. If you try to pour fluid into it quickly, it does this. It won't stretch or accommodate. But if you try to fill it up slowly, it can stretch over time. And so what you can see here is that just because you have a lot of fluid doesn't mean that the pressure is high. If it develops acutely, if you go from 150 cc's to 250 cc's, so I just add 100 cc's, whoop, my pressure is going to go from negligible up to 20. So this is how you can get acutely into tamponade with trauma, for example, during procedures if we accidentally, rupture your pulmonary artery or something and it pours into your pericardium. It happens. So this shows you that in a non-compliant normal pericardium, a little bit of fluid makes a huge difference. Look at this person who's chronically overloaded and chronically has a pericardial effusion. It's actually a mouse, not a person. So this mouse sits with a large volume, or maybe it's a pig or something, a large volume of fluid, and to go from 350, I don't get a change in pressure until I'm all the way up to 550. I've poured 200 liters in there, 200 milliliters. So the rate at which it accumulates really matters in terms of whether the pressure rises or not. And that's why you can have a large, just because it says large pericardial effusion on the echo report, don't get excited. And you know this, but I'm telling you why. It's because if that fluid accumulates relatively slowly, then the pressure in the pericardium will not start to increase rapidly. Effusion does not equal tamponade. You got it. Okay, so how do you treat tamponade? So this woman that I had in the ER, I diagnosed her with tamponade. So what do I do? Just stick a needle in the chest, go for it yourself? No. Okay, so what's the better alternative? No one? So call an interventionalist. Absolutely. This is an emergency. They'll come in, this is like a STEMI. They'll come in and do this immediately. What do you do while you're waiting for them to come in? This woman was not perfusing her brain. What can you do to support their blood pressure in the meantime? So let's say that it's someone who has a blood pressure of 70/40 and they're symptomatic, so a little bit different than my lady. So your first step is actually going to be fluids. The reason is that you're actually just trying to kind of force the pressure inside the right ventricle to be higher than what's in the pericardium. So if I can just give you some more preload, I can at least in the short term raise the pressure in the right side enough so that I'm not being impaired by that pericardial pressure. So I give some IV fluids, but really something only like up to 2 liters, because if I give more than that, I'm actually going to start to put it in the pericardium. I'm also going to have stretched my right ventricle, and now I'm going to be putting more pressure on the pericardium. So you can't just slam them with fluids, but I'll give them like 1 to 2 liters. And if you have central access or you're getting central access, your goal is to get them to a CVP a little bit more than normal, so maybe 15. You can also use things like dopamine to support the blood pressure or pressors if you need to while you're getting the person in. Now, if the patient is coding, right? Because remember, that's one of the H's and T's, tamponade. If they're coding in front of you and like it's going to be half an hour before someone who's done this before can get there, you are totally within your rights to try and do a pericardiocentesis on that patient. But if they're not coding, you should wait until someone gets there that knows what they're doing. If you have to do this emergently, does anyone know how to do it? like that? No. So there's actually a pericardiocentesis kit, so it has a needle there. You want to go subxiphoid and you aim for the left shoulder. So you have to go right subxiphoid, you push the needle down to try and get underneath the xiphoid, and then you just aim at about a 45-degree angle up and towards the left shoulder. And you want to be pulling back as you go in, and the goal is that you hopefully get some straw-colored fluid. Now, the scary thing is if you get blood, because what's the risk in doing a pericardiocentesis? What structures might you hit on the way in with that approach? What's that? If you hit the liver, you're definitely aiming incorrectly, but sure. So the right ventricle is of one concern, yeah? So if you somehow went too fast, so you didn't actually hit the fluid pocket, or if the fluid pocket was small, and you hit the right ventricle, then you're going to pull back frank blood. So if that happens, don't panic, because the right ventricle, it turns out, I mean, there's a lot of things we can do to help in that situation. If it's an emergency, you actually can send that blood to the lab and get a sat off of it so you can figure out what kind of blood it is, arterial or venous. But if you actually end up just pulling the needle back into the pericardial space, the RV will seal on its own. So that's actually less of a concern. The biggest concern is if you hit what structure that runs along the outside of the RV. The RCA. So if you hit the right coronary artery, that's an arterial bleed, and it will fill up the pericardium, and the patient can need emergent surgery or death. So that's actually the biggest concern, is hitting the coronary as opposed to actually hitting the RV. So if you ever have to do it, that's the situation. Most of the time, if you're doing this on a coding patient, it's very unlikely that you're going to be successful and get them back. But again, if you have a high suspicion that this is like a free wall rupture, or for some reason you think like it's a trauma patient, this can be life-saving. But again, when you have a pericardial effusion and you're thinking about treating them, don't just get excited like, woo, they're going to come in and stick a needle in the chest. You got to be thinking about why they have this. And when you get the sample of fluid, you only have one shot at it. So you want to send it to the lab for all the appropriate stuff. So you have to think about malignancy, tuberculosis, Lyme disease. I've actually seen Lyme pericarditis, infection, post-cardiotomy syndrome, trauma, etc. So keep in mind a differential diagnosis and make sure you send the fluid off for those in studies. We already talked about this. Okay, so any questions about tamponade before I move on to just a few other types of cardiomyopathy that will play into this? Yes, no? Good, you're all ready for it? Okay, so I want to talk about constriction and restriction, because these are things that people get frequently confused. And the same physiology we just talked about for tamponade, we can apply it to these cases. Does everyone know what I'm talking about when I say constrictive versus restrictive physiology? Is that familiar? Raise your hand if you've ever even heard those terms before. Ooh, okay, 50%. Okay. You may hear someone bring this up and say, oh, I think that this person has a restrictive cardiomyopathy, or I think they have constrictive pericarditis. So I'm going to teach you a little bit about that. Hang with me, okay? Your brains are going to stretch, but you can do it. So constriction is just what it sounds like. The heart is sitting inside a steel box. Something externally is compressing and constricting the heart. So the best example of this is if you have a calcified pericardium for some reason. So that pericardial sac, instead of being nice and compliant, is just like a steel box, and that's going to limit the movement of the heart inside that. The myocardium, this is the key to differentiating between these two things. The myocardium is normal. The muscle of the heart is normal. It's just inside a steel box. So the septum, which moves, as we've just been discussing, it can move normally, just like it normally would. But the heart's sitting inside a steel box. That's constrictive physiology. What can cause this? A calcified pericardium, which can be from tuberculosis. You could have radiation to the chest that causes that pericardium to be calcified. Any history of pericarditis, if it is fibrinous and kind of solidifies down in the pericardium, that can cause constriction or malignancy. There's also a term called effusive constrictive pericarditis. This is where you have both an effusion that's potentially causing tamponade, and you also have constriction because there's a thick and non-mobile pericardium. Don't worry about that. Okay, good. So this physiology is just like tamponade, right? Because in tamponade, I just made my pericardial pressure high. Now I'm just saying the pericardium is like a steel box. So the physiology of what happens is exactly like that, and we'll go through it in a second. So these are some people who didn't do so well. So this is an example of a really thick pericardium that someone got that could cause constriction. You can imagine that, right? Your heart is not free to move as it wants to when it has this very thick pericardium there, but the septum is normal, so it can move back and forth to accommodate changes in that preload, just like a normal heart would. This is a normal thickness pericardium, but this is someone who had pericarditis, and so even though it's of normal thickness, it can't really distend very well, so it still creates that steel box phenomena for the patient. Now, let's talk for a second about restriction. Restriction is actually where there's something wrong with the muscle itself. So the muscle is abnormal, usually because it has some sort of infiltrative disease. So something is inside the muscle that doesn't make it relax properly. Can anyone for a bonus point tell me what's the classic restrictive cardiomyopathy, the classic infiltrative disease? Amyloidosis. Good, you all get bonus points and no candy because someone ate it. Okay. So amyloid leads to restrictive physiology. So here now, the septum is abnormal, and so that's going to differentiate our physiology because the muscle is all abnormal in restriction. Something is in there. So the differential for this includes amyloid, but also hemochromatosis. I've had a case of that where you have the iron deposits. Diabetes can actually lead to this. Sarcoid, glycogen storage disease, Fabry's, etc. Any sort of deposition that ends up in the myocardium will lead to the muscle being abnormal, and it's usually a problem with kind of relaxation. So maybe you've never learned this, but when I was coming up, we learned that it was very difficult to distinguish between these two because you could imagine how the physiology might be similar. But I'm going to teach you a very simple way to remember. This is just an example of amyloid. So you can see that the walls of the heart are thickened. This is a short axis view. So you've taken the ventricle, cut it in half, and you're looking at it like a donut. These walls are too thick. And then look here, left ventricle, left atrium, right atrium. This is showing atrial enlargement, which is also a hallmark feature of amyloid. But do you see how thick this myocardium is? It's been infiltrated with something. And if you actually look, what it's been infiltrated with are all these deposits of amyloid. Remember the whole biorefringence, apple green biorefringence under polarized light? Boom! How you like me now? Okay. So this is amyloid. So the way to differentiate between those two things is just to think about the septum. In constriction, it's normal. The heart's in a box. In restriction, the septum is abnormal because something has infiltrated. So this leads to a concept called ventricular interdependence. You ready to hang with me? Here we go. Okay. Woo! All right, let's do this. So this is the left ventricle are the bigger numbers. The right ventricle are the smaller numbers. These are catheters that are in both ventricles. This is the only way to diagnose the difference between these two. You got to dip in the left and you got to dip in the right. And you measure both ventricles simultaneously. So what you see, left ventricle, everyone's familiar with these pressure tracings, yes? A ventricular pressure curve. You learned it sometime in medical school. Okay. So with inspiration, I'm looking to see what happens. I'm looking for ventricular interdependence. What does that mean? Well, think about what happens in tamponade, what we just talked about. If the pressure in the RV goes up, what happens to the pressure in the LV? In tamponade, it goes down, right? Because the septum is moving freely. So the pressure in the RV goes up, the pressure in the LV goes down. That's called discordance or ventricular interdependence. The one depends upon the other. So let's see what's happening in this first slide. So I take a deep breath in, inspiration. My LV pressure is going down. My RV pressure is going. So the scale is a little bit low, but it goes from here to here. Yeah? So my RV pressure goes up and my LV pressure goes down. So do you think that this is constriction, where the heart's in a still box and the septum is normal, or is this restriction where the septum is not normal? What do you think this one is? This is constriction because it's just like tamponade. Deep breath in, intrathoracic pressure goes down, preload goes up, RV filling goes up, RV pressure goes up, septum shifts over to the left because it can't go anywhere in the box, LV pressure goes down. Ventricular interdependence. Okay? Good job. Now, over here what we see is I take a deep breath in, my LV pressure goes down, and what happens to my RV pressure? It also goes down. So this does not suggest a septum that can bow to the left or the right to accommodate the change in preload. This suggests that you have concordance. The whole thing is abnormal because the septum cannot move normally. So this is actually going to be restriction over here. So the key takeaway point, this is a lot, I know, but you can bend your brains, I believe in you. The key take-home point is that in constriction, the septum is normal because the muscle is normal, but the heart's in a steel box. So the hallmark feature is ventricular interdependence. In restriction, the muscle is abnormal because it's been infiltrated with something, and so therefore the septum cannot move normally, so you don't have ventricular interdependence. Whew! Okay, take that home and chew on it. You can watch that again later. But this is important to know about these entities. I want to switch gears for the last 5 minutes and talk about two other very quickly topics about other kinds of cardiomyopathy that you may not encounter. Because normally you're used to thinking about systolic heart failure or ischemic cardiomyopathy. Who knows what stress cardiomyopathy is? Raise your hand if you know that. Takotsubo, if I say that, does it raise anyone else? I call it stress cardiomyopathy for a reason. So this is the Sentinel article. This is by one of my mentors. It's the Valentine's Day edition, Valentine's Week of New England Journal, talking about stress cardiomyopathy. And this is really where this came into the American press. So there are a couple of different features that you have to fulfill in order to count as stress cardiomyopathy. I'll give you the first one, a stress. Emotional, physical, doesn't matter. I've seen it from surprise birthday parties, meeting your biological parents for the first time. My favorite one, facelift, getting all the little epi injections, and then crashes and burns on the table, and they bring her into the CCU with like drains in her face. That one was kind of awesome. Okay, what other criteria do you know of for stress cardiomyopathy? Okay, good. So you can't have an MI that explains this. So it's a diagnosis of exclusion. So no coronary disease that explains the pattern of LV dysfunction. What else?
Reversible.
Good. So it should get better within 6 or so months. That's 3. What else? I gave you the first word in the name. What about the second word in the name?
Echocardiographic.
Yeah, so you have to have LV dysfunction. And it should be in a certain pattern. And it's a non-coronary distribution. So there's 3 different patterns, which I'll show you. You were used to thinking of that the apex of the heart is ballooned and the base squeezes. But you can also have where the apex of the heart squeezes and the base doesn't. Or you can have the mid-ventricular variant, where it looks like a top. So the base and the apex squeeze, but the mid doesn't. But those are non-coronary distributions of LV dysfunction. Good. What else? There's our EKG and troponin criteria-ish. Okay, good. So exactly, just like you said. So the troponin elevation is usually lower than what you would expect for that degree of LV dysfunction. So somewhere around 5 to 10. I have seen it higher, but usually you're like, wow, their EF is 10%, but their troponin's only 7. And then there's some classic EKG findings, which I will show you. ST elevation is possible. I've seen that. QT prolongation develops in the hospital stay. It's not usually on presentation. It's about 48 hours afterward. These deep, symmetric, nasty-looking T-wave inversions that make you think of intracranial hemorrhage or Wellens T-waves. And then all these EKG changes should resolve, usually around 5 or so days. And then we talked about the LV dysfunction. Good. Okay, so here's a patient. This is their admission ECG. This is sinus tachycardia, And you might see a little bit of ST elevation here in V2, but less than 1 millimeter. And the QT looks a little prolonged. Everyone can agree with that? Okay, watch what happens at 48 hours. Holy mama! Look at these giant, deep, symmetric T-wave inversions in a QT that's like the length of the Mississippi River. It's so long, right? This is a nasty looking EKG, but it's diffuse all through these precordial leads. Now here are some examples. So this is going to be diastole and this is systole. So this is a V-gram in the cath lab. So this is when it's filling and then that's when it's squeezing. But do you notice that the only walls that squeeze is right here at the base? So those 2 walls squeeze, but the rest are ballooned out. That's the classic Takotsubo shape. That's the shape of an octopus pot in Japan. The reason I don't call it Takotsubo is because you have other options. So here it's filling and here it's squeezing. So notice the apex is obliterated. It's like a spade shape because the apex squeezed down, but the base did not. The base stayed ballooned. So that's one of your other variants that you can have. Oops. What was this? MRI findings. Again, here's diastole, here's systole. So this is the classic one that you're used to thinking of with the apical ballooning and the base squeezes. And then, I'll skip that. Same thing. Okay. So, I just want to show you what this looks like on the echo. So, here is the left ventricle, right ventricle, left atrium, right atrium. See how all of this out here, it's not moving. It's not getting thicker. It's not moving towards the center. But down here and here, at the base, both walls are thickening and moving towards center. So, this is a pretty classic finding for stress cardiomyopathy. Then, I want to show you what happens This is one of the dreaded complications. Anyone can tell what's in here already? Uh-oh. So you've started to get better. Do you see how some of these walls are starting to squeeze? What's that? Woohoo! That's an LV thrombus sitting in the apex. Bad news bears. But then here is recovery. So this is just a couple of weeks later. So now you can appreciate that all these walls are squeezing and moving towards center. There's still a residual LV thrombus there, but you see how all of the walls are squeezing. You could understand why this is particularly dangerous, right? Because if you had this thrombus sitting in an akinetic apex and then all of a sudden the apex starts to squeeze, that's a great way to get a stroke. We literally had a patient have a stroke on the front lawn at discharge. Because she had a thrombus, anticoagulated, sitting on the front lawn waiting for a ride to come pick her up. The thrombus goes upstairs and has a stroke. This is just to show that the ejection fraction improves. Within 2 to 4 weeks as an outpatient in this series, the EF went from 20 to 60%. So it really should improve, and it should improve relatively quickly. We don't really know what causes this. We'll always say, oh, you might beta receptor density. Nobody really knows. We think there's something to do with calcium cycling. We think it has something to do with catecholamines, but we really don't fully understand the pathophysiology. There is a female preponderance for this. And there's a higher proportion of people who've had some sort of previous psychiatric diagnosis like depression or anxiety. Treatment is really just like you treat anybody who has cardiac dysfunction. If they're in cardiogenic shock, you just manage them like anybody else with cardiogenic shock. If they're in heart failure, you manage them like anyone else with heart failure. We give them, if they do have apical akinesis, this is not evidence-based, but I will anticoagulate them because I showed you those horrifying pictures of what can happen. So I will usually anticoagulate them even in the absence of an LV thrombus until they come back a month later in clinic and the apex is fine, and then I'll stop the anticoagulation. We give them standard heart failure therapy, and we usually will continue it for a couple of months until their LV function has resolved. So usually 6 months to a year, I'll keep them on those. And I repeat the echo at 1 month after diagnosis. Okay, 2 seconds about HFpEF and then we'll be done. Who knows what HFpEF is? What's HFpEF? Yeah, so this is the correct term. You should not be saying diastolic dysfunction. You can say non-systolic heart failure, that's fine. But HFpEF is really the term that we use to discuss this. HFrEF, what's that? So that's your typical LV systolic dysfunction. So HFpEF is, this is actually kind of hot right now. So we may call it all these other things, but HFpEF is the term that I prefer. Now, do not give this name to all heart failure that have a normal ejection fraction. I came on service once during my fellowship, and they told me that everybody on the service had HFpEF. Well, then I went through and well, they don't have HFpEF, they have aortic stenosis. That's totally different. So just because the LV function is normal and they have heart failure symptoms, it doesn't mean they have HFpEF. If they have valvular disease, if they have amyloid with restrictive cardiomyopathy, that's a different diagnosis. This is someone who has normal systolic function, heart failure symptoms, no other reason why. If you call one of these, or pulmonary hypertension to call it HFpEF, that's incorrect also. So you gotta know what you're diagnosing here. We really don't understand this mechanism at all. If you can discover that, good job, you'll win some big prizes. But we think that about 50% of all heart failure in this country is actually HFpEF, so you gotta know about it. What medicines are evidence-based to improve mortality in HFpEF? Name them. None. That's absolutely correct. Now, the ROSE-HF study that was just published last year, TopCat, was a spironolactone in HFpEF patients. And if you actually take out Russia and Ukraine, I know, I'm starting to split hairs, but if you take Russia and Ukraine out of the analysis, grossly positive study. And the reason why I find that interesting here is because diagnosing HFpEF, easy or hard? It's actually kind of hard to diagnose HFpEF. And it's probably also difficult to control what they're calling HFpEF. So it's possible that those centers were not actually enrolling the same patient population. I also think HFpEF is probably 3 different diseases. So I think it might be reasonable. There's no evidence base for spironolactone, but I think if we repeated that study, we may find a positive result. So I will often give them spironolactone, but knowing that it's not in the guidelines. So there have been a lot of trials, they've all been negative, so we just end up treating these people for their volume overload and for their risk factors. The risk factors that we know of, obesity, metabolic syndrome, hypertension, And so we diurese them, and then we try to treat their comorbid conditions: sleep apnea, weight loss, smoking cessation, etc. So this is a difficult beast of burden here.